Hello, well, I'd like to welcome you back from your break, and I hope you've had a chance for a coffee and a little bit of networking. Um, I'm sitting here feeling completely mind blown about the excitement and all the kind of technology and everything from this morning. It's been a wonderful morning, and so I hope we can carry on. And I'm going to welcome Umberto Manera, who's going to be talking about the anxiety shows higher in the progressive role of ALS than depression. So thank you, Umberto.
Good morning, everyone. I'm Umberto Manera. I'm a PhD student and neurologist from Turin, and I'm pleased to have the opportunity to present the result of a study on the prognostic role of anxiety and depression in ALS patients. Some studies have already investigated the impact of psychological status on clinical outcome. In a study performed in 1994, a psychological status score was derived from 10 psychometric tests, comparing only high and low psychological scores, but without taking into consideration the specific, independent roles of anxiety and depression. In the last few years, the prognostic role of anxiety and depression has been evaluated in many neurological and non-neurological conditions. For example, in patients with primitive brain tumors, glioma, these two conditions were present in about one-third of patients, independently from disease stage and disability. Interestingly, in these studies, after adjustment for multiple confounders, an effect of overall survival was found. Considering ALS patients, specific personality traits have been found to be different from age-matched controls, partly explaining the general impression that ALS patients have a very mild character. Specific personality traits such as agreeableness are related to a faster disease progression and to a steeper reduction of quality of life assessment scores. The vast majority of studies investigating depression and anxiety were mainly based on cross-sectional assessment of both conditions and their relation to disease severity, to cognitive impairment, to age, and caregiver burden. Anxiety resulted to be generally more frequent than depression in most of the studies, especially in the earlier phases of the disease. Poor emotional well-being, defined by ALS assessment questionnaire, the ALSA-Q40, specific items, has been associated with a faster disease progression, but not clearly with a reduced survival. Also, premorbid anxiety was not significantly different in ALS patients compared to healthy controls, but interestingly, ALS patients show high levels of resilience. Using our data, we primarily investigated the prognostic role of anxiety and depression in ALS patients, adjusting our analysis for different motor and cognitive confounders. We retrospectively collected all the hospital anxiety and depression scale questionnaires, performed as a part of a neuropsychological baseline evaluation at diagnosis. HADS is a widely used scale specifically developed to be a useful tool for the detection of anxiety and depression in people with physical health problems. 7 items measure anxiety and 7 items measure depression. A score from 0 to 7 is considered as normal, a score from 8 to 10 is considered as borderline, and a score from 11 to 21 as abnormal or case. We analyzed the data of ALS patients followed by the Turin ALS Center over a 10-year period. We performed a correlation analysis between the HADS scale and many clinical features, such as age, sex, education, ALSFRS score, delta ALSFRS, onset diagnosis interval, and cognitive categories, stratified using the strong criteria for ALS FTD categories. Then we performed a survival analysis using Cox proportional hazard models, adjusted for the same clinical features and Kaplan-Meier curves. We obtained data from 569 patients at diagnosis. Median anxiety score was of 7 and median depression score was 5, a slight lower than anxiety. Using standard heads cutoff, we found that anxiety was present as borderline or defined in about half of the patients, while depression was slightly less frequent. Considering the severity score, the majority of anxious patients showed only mild to moderate anxiety. Median anxiety scores resulted to be significantly higher in spinal patients, while depression scores did not differ significantly according to the site of onset. Anxiety and depression resulted to be moderately correlated among them. Depression resulted to be positively correlated with age and cognitive impairment, and inversely related to total ALSFRS score, while anxiety showed only a mild correlation to total ALSFRS score. Considering univariate analysis, both anxiety and depression resulted to be related to overall survival. Adjusted Cox model showed that anxiety, but not depression, was related to a higher risk for death tracheostomy. The best discriminating cutoff for the head's anxiety was 6, a score lower than borderline case, that confers the patient an hazard ratio of 1.45. We then analyzed the effect of depression in patients stratified for anxiety subscore, and we found, interestingly, that depression resulted to be a prognostic factor only in patients with comorbid anxiety, with an hazard ratio of 1.57 for the HD score higher than 6. In conclusion, we found that anxiety is more frequent than depression in ALS patients at diagnosis, and unlike depression, it seems not to be related to specific motor and cognitive features. We also point out that anxiety plays a role as an independent prognostic factor in ALS, similarly to what observed in both neurological and non-neurological conditions. Considering our data, we ask ourselves what are the interpretation of our findings. A possible explanation is that anxiety and depression lead to a reduced survival by worsening quality of life, motivation, therapeutic adherence, as it is already seen in other non-neurological disorders such as coronary heart disease and leukemia. In this case, mood disorders act like independent worsening factors. Another explanation is that both anxiety and motor neuron loss are manifestations of neuropathological involvement of common neuronal pathways. The neuronal circuitries of anxiety and mood disorders are located mainly in the frontal and prefrontal cortex. Recently, brain areas like amygdala and medial prefrontal cortex, that are important nodes of anxiety pathways, have been found to be altered in patients with ALS and primary lateral sclerosis. In this case, anxiety could be considered as a proxy of extramotor involvement in ALS. A third possible interpretation is that anxiety could negatively affect disease progression by enhancing neurodegenerative mechanisms such as neuroinflammation and excitotoxicity. Considering this intriguing hypothesis, anxiety could be considered as one of the determinants of disease progression. In this case, treating anxiety might be helpful not only to improve quality of life, but also to slow down disease progression. Our study is not without limitation. Principally, we still haven't completed the collection of longitudinal health assessment and the use of medication for depression and anxiety. Future studies considering biomarkers, neuroimaging, and neurophysiological techniques are needed to solve our unsolved questions. Thank you very much for giving me the possibility to present our data. I would like to thank all my research group members, especially our neuropsychology team, and you for your attention. Thank you very much.
Thank you, Umberto, for that very interesting presentation. Are there any questions for Umberto? So Umberto, while we're just waiting, because people are still on the chat, you'll be able to see them coming up. But do you have any advice for, on a practical level, with knowing this knowledge, for specialist teams, specialist nurses like myself, that how we could actually use this to help our patients when we see them in clinic?
Yes, the results of our studies are particularly interesting because anxiety is now considered just as an epiphenomenon and mainly related to the burden of the disease. But using this data, we also think that anxiety and depression could act also in the worsening of the disease. So patients with anxiety have a different disease course compared to patients without anxiety. Considering our data, we are not able now to weigh the effect of the therapies of anxiety and depression. We are not able to measure it, but we are now collecting all the data because for this specific study we analyze only the data obtained by using the scale I mentioned, the HADS, and we are now collecting also the data on drugs. And as a neurologist and important to support patients in measure with anxiety and depression, and we have the sort of clinical, we start this study because we have the clinical impression that patient without anxiety seems to get lesser worse than patient with anxiety and depression. So we usually use medication and psychological support for anxiety and for depression in ALS patients. And as a neurology, we see that not only the psychological status of the patient get better, but also the motor part of the disease is better when the psychological status is controlled, is treated. So is especially in the last years, we pay a particular attention to the psychological status of patients. We especially checked it.
Thank you very much. And there's
Thank you.
from the chat, I think it's Becky suggesting that you get together with the previous speaker for some collaborative working.
Yes.
I think that may actually work towards helping your patients a lot.
Yes.
And it's people are just saying, and Anna, who the previous speaker, just saying how important it is, and she'd very much like to work with you. So I just have one other question. Actually, you talked about at the beginning of your presentation about resilience and how that was actually surprisingly high. Why do you think that is so? It's a high.
We don't know, because the study I mentioned is particularly interesting because it's the only one who specifically measured resilience in ALS patient in a premorbid condition. So it was a retrospective questionnaire, and we tried to measure the capacity of patient that after developed ALS. The measure used try to explain the differences in the possible burden of stressors in previous life that can cause ALS, but they found quite the opposite. So it seems the ALS patient has a higher resilience than normal control, and it's probable that patients with ALS have a different genetic background. This is a possible explanation, but we actually don't know what is the correct answer for this question. I think it's very interesting, but it's the only one study available so that measured that.
Okay, well, thank you very much. That was a really interesting.
Thank you.
And I think you and Anna are going to have your work cut out for you in the future. So thank you for that.
Very much.
Would you mind, as Sarah was saying, would you mind keeping an eye on the chat and answering any questions that
yes.
Following this, your talk? But
yes.
thank you very much.
Thank you very much.
Really.
Bye. Bye. Bye.